Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jenny Berkovich, board-certified pediatrician and director of education for JOMA. My guest today is Dr. Ruben Quintero, where we talk a lot about his work in fetal surgery, or fetal therapy, as he called it. He is a graduate from the Central University of Venezuela, Luis Rossetti School of Medicine. He did his residency in obstetrics and gynecology and maternal-fetal medicine fellowship at Yale University, and he is internationally known for his pioneer work in fetal therapy. Using the principle of limiting fetal interventions to minimal invasiveness, Dr. Quintero developed all of the necessary tools and instruments, surgical techniques, and disease classification that guide the treatment of many fetal conditions today. He has over 20 years of experience in the management of complicated pregnancies and has performed more than 1,000 fetal surgeries. Dr. Quintero has a productive academic career, including the publication of the famed Quintero Staging System, which is used in the assessment of patients affected with Twin-Twin Transfusion Syndrome. He is the editor of the first book on Twin-Twin Transfusion Syndrome, as well as the book on diagnostic and operative fetoscopy. I want to add a trigger warning to the episode. We do mention miscarriages, pregnancy loss, and high-risk pregnancy. I hope you enjoy the episode. Hi, Dr. Quintero. Welcome.
Well, thank you. Thank you very much.
I'm thrilled to speak to someone in your specialty. It's not common. It's not usual that we have someone who has expertise in fetal surgery. So before we start, maybe let's set the tone and tell me a little bit about what somebody in your specialty actually does. What are the typical things that you see patients for, and maybe typical procedures that you perform?
Well, we are by trade obstetrician gynecologists. Then maternal-fetal medicine specialists. So we take care of high-risk pregnancies. And then above that or beyond that, we developed methods, techniques to treat birth defects in high-risk conditions before birth to avert death of the baby or death of the fetus, or to improve the quality of life of that baby after birth. So we typically see patients with high-risk pregnancies, very, very complicated pregnancies that require both the evaluation to determine how significant the condition may or may not be, and if the case may be, then some form of treatment.
Thank you. I think when people hear the concept, certainly when I hear the concept of fetal surgery or fetal intervention, it sounds wild. It sounds like sci-fi. Tell me a little bit about just the concept of how that even works.
Well, fetal surgery or fetal therapy used to be sci-fi. When I started this many years ago, the only option was to do a very large abdominal incision and operate on the baby openly, and then put the uterus back together and the abdomen back together. So that was not very appealing, and there were very few indications for that approach. So because my basic training is in obstetrics and gynecology, and we understood that the human uterus was not really keen on undergoing such invasive procedures, I decided to develop a different approach, which was to be able to fix things with very small instruments that would not require opening the abdomen or opening the uterus. So yes, it was sci-fi at the time. It isn't a sci-fi anymore. It is actually almost commonplace. Patients now, if they, for example, are diagnosed with X or Y condition, and they go on the internet, they can find that there is an option, that there are treatments available for that condition. Again, this was not the case, 20, 25 years ago. When we started this, I mean, like you said, this was science fiction. And, you know, it was actually dangerous to get up in a podium and talk about any of these things because, people will go to the supermarket before coming to the meeting and buy as many tomatoes as they could buy and then throw them at you. So
Because and the controversy is what? That you're proposing treatments that are considered dangerous. Like I'm thinking it from the terms of a risk benefit, right? If you're dealing with something that's lethal, the risk is that the babies are not going to survive. What's the controversy with what you're proposing?
well, no, the original controversies were based on, for example, the rationale for the surgery. The best example was Twin-Twin Transfusion Syndrome. So in Twin-Twin Transfusion Syndrome, one baby is giving too much blood to another one. The baby that's giving too much blood can die from hypotension. The baby that's getting too much blood can die from heart failure because it's overwhelmed with blood. Okay, so the proposed treatment was, okay, we have to go in there with an endoscope. We have to find the vessels and occlude the vessels. Okay, when that was proposed, there was no real description on how that could be done. No real description. So because there was no real description, people did not believe that that was feasible. You cannot do this. In fact, to this day, there are still publications that say that there are underground vessels that you cannot see and therefore you cannot find and therefore you cannot occlude. So there was this skepticism about the possibility of being able to identify the culprit vessels and occlude them. So we took on the task of determining if that in fact was feasible or not. So to do that, we didn't go and start doing surgery on patients. We took placentas. We looked at the placentas outside. And we said, wait a minute, look at these vessels. This is how they connect. This is how they don't connect. So this vessel shares blood, and this vessel doesn't share blood. So therefore, if we were to be able to do this in utero with an endoscope, we will be able to separate them.
Wow.
Okay? So we proposed that, but again, it was like, we don't believe you. This is not real. This is hocus pocus.
And then
So
once you had a patient outcomes, was it a
right,
different conversation? I'm assuming when you share your survival rates and success rates.
exactly. So then we started publishing. We started saying, excuse me, this is not science fiction, like you said. This is real. We can get in there and we can find the vessels and we can occlude the vessels, and this is how you do it.
Wow.
So that was a big difference. To give you an example, that when we came into this, let's say the game had already started. Okay, we came in like in the second quarter. Okay,
Okay.
the game had already started. So other people, for example, in Europe, they didn't think that they could identify exactly which were the vessels. So they resorted to occluding anything that would cross the membrane that separates the two babies. So the babies are in different sacs. Baby A is on the left and baby B is on the right, for example. And there is a membrane that separates them. Well, the people in Europe would go into these pregnancies with an endoscope, and any vessel that crossed the membrane, they would occlude if they cross the membrane. Assuming that, in fact, the vessels that cross the membrane are the culprit vessels. So when we published our technique, and this goes back to 1998, when we published the technique, we said, guys, that is not the way to identify the culprit vessels. The way to identify the culprit vessels is to look at each vessel and see if it communicates with the other baby or not. Why? Because there are many vessels across the membrane that, in fact, are not sharing blood. So when you occlude vessels that are not part of the blood sharing scenario, you can hurt the babies. So in the first series that was published with that technique, where they would actually interrupt all of the vessels crossing the membrane, they would lose half of the babies. Half of the babies
Wow.
would die. Today, we only lose 10%. And not because we're not doing it right, it's because
Right.
if the babies don't have enough placenta to survive by themselves, there's nothing that can be done, to change that. But, and this is how we name the technique, we'd say the selective technique. Why is it selective? Because it's not indiscriminate. It's not cutting off anything that looks blue. It is precisely identifying which vessels allow the babies to share blood and occlude only those vessels. And that's how, things have evolved. Now, there are setbacks, there are, let's say, backward steps in Europe, for example, because they're frustrated with not being able to do this very precise, elegant surgical technique. They resort to lasering everything in between. So they identify the vessels that are culprits, and then they still burn the entire placenta from end to end. We don't do that. Why? Because the placenta is what the babies require to live. They depend on this. If you burn healthy placenta, you are not helping them. You are hurting them. So we use a watchmaker's, precise identification of the vessel, and we occlude only those vessels. And with that, we have the highest success rate that, can be cited. And
That's
that
really
makes
amazing.
sense. That makes sense.
Really
So yeah, it's
amazing.
been a a challenge to go from science fiction to, commonplace.
What are some, I don't want to say common, but maybe that is the right word. What are some common things that somebody might find as a solution via fetal therapy for some maybe conditions or things that are the standard of care is appropriate for conditions?
Well, we can classify the different conditions in two ways. One, the ones that are lethal, meaning the ones that unless you intervene, the fetus will die, or the pregnancy will be lost, or the baby will die after birth. Fetuses, by the way, can live in the womb without many things. They can live without kidneys, they can live, with a malformed heart, they can live with many things. Outside the womb, that's not the case. You have to have, your organs well developed and everything. So one classification is the conditions that are lethal, meaning they are going to result in death of the fetus or death of the baby after birth, unless you do something. Now, there's another, within the lethal, there are, let's say, situations where there's nothing that can be done. If the baby
Not
does,
things are just not compatible with
right,
life, and
not compatible with life.
no intervention
Right,
exists
so
right now.
baby doesn't have a brain, there's no surgery that you can do to fix that.
Or I would think some chromosomal abnormalities, some trisomies that we know are not compatible with life.
For example, some conditions within the lethal, you have to specify lethal treatable versus lethal non-treatable. The other group is non-lethal conditions, but that without intervention may cause harm to the baby. For example, the baby has a blocked aortic valve. If there's a blockage of the valve in the heart and you don't do anything, there is a chance that the baby can lose that portion of the heart, for example. It withers away, literally.
Mm-hmm.
So if the baby is born without that portion of the heart, then although that is not going to necessarily cause the death of the baby or the fetus, it will result in requiring several surgeries after birth, trying to make the heart function with only one chamber, for example, to pump blood for the lungs and for the rest of the body, etc. So it's a different situation. So that's the first type of classification. The lethal ones that are treatable, of course, and the non-lethal ones that nonetheless can result in a quality of life, can affect the quality of life. By the way, in that example of the blocked valve, if you intervene in utero and you unblock the valve, then all of a sudden the heart wakes up and the heart doesn't wither away, and the baby's born with, a functioning heart, and the baby can have a good quality of life. That's an example.
How do you make the distinction that in utero intervention is preferred versus operating on the baby after they're born? Things like heart valve surgeries. I don't want to say they're mundane. It's right. It's certainly extensive and serious, but neonatal surgeons, right, or pediatric surgeons, or cardiac surgeons, right? They operate on babies' hearts all the time. Those techniques have been around for a long time. How do you decide the risk versus benefit of in utero intervention?
Well, before I answer that one, let me finish the other classification.
Okay.
The other classification has to do with whether the condition affects one baby or the condition has two babies, twins, because many of the surgeries that we do, for example, involve twins. And the third, if you could add a third, has to do whether you're operating on the baby itself or you're fixing something else. For example, you're operating on the placenta or you're trying to fix the membranes. That has nothing to do with the baby. So these are in bird's eye view, the different types of scenarios that we could encounter to offer fetal therapy. Now, how do you decide that antenatal intervention is recommended? That falls into a realm called surgical criteria. And it has to do with what we now know or, seem to know about what's called the natural history of the conditions. So before ultrasound was available, we did not know what was happening inside the womb. And the babies would be born and the babies had X, Y, or Z problems. But now that we have ultrasound, we can detect a problem. And if we can detect a problem, we know what happens along the course of pregnancy with that particular problem. For example, if a baby has a cleft lip, well, we know that that's not going to progress. That's going to remain like that until the baby is born. So, would there be a reason to intervene in a cleft lip? Maybe, to take advantage of the in utero environment, increase function, etc. But we know that that particular birth defect doesn't progress, doesn't get worse.
Right.
Okay. Whereas there are other situations where we know that the natural history is such that things get worse along the way. So, for example, if a baby has a blockage of the bladder, cannot urinate, well, that's not going to get fixed by itself, number one. So, in very rare occasions, does it actually, something happens and it frees up, but
Right.
in most cases, it doesn't happen. So the baby has a blocked bladder. The blocked bladder produces damage to the kidneys. So the baby's kidneys become damaged along the way of the pregnancy. They're not damaged immediately, but they become damaged along the way.
Mm-hmm.
By the way, some of these notions also come from animal experiments when there is an animal model that can simulate what happens in the human. So for example, in this case of the bladder obstruction, the animal model is not a blockage of the bladder. The animal model is blockage of the ureters, which are the little tubes that connect the kidneys with the bladder, because in the animal, blocking the bladder is very difficult. So
Mm-hmm.
the animal experiment is blocking the ureters. If you block the ureters in an animal model, you see that if you don't unblock the ureter, along the way, the kidneys become damaged. And so the rationale is, okay, well, if there's a blockage, we're not going to let the kidneys get damaged. We're going to do something about it and make sure that we free up the obstruction, for example. The other thing that we also know in terms of this natural history concept is that there's a window of opportunity. If you don't intervene at a certain point, the organs no longer can be saved. This is the case, for example, for this topic of the bladder obstruction. If you don't intervene in a timely fashion, then the baby's kidneys are beyond being salvageable, for example. So, for each and every fetal condition, we in particular have proposed criteria. When do you offer treatment? Now, in a very simple way to analyze this concept of when do you offer treatment or why would you offer treatment, okay? In one end of the spectrum, there are conditions that even though you can diagnose them, they will not progress, they will not cause further damage, and therefore it's just better to wait until the baby's born and the baby can be treated.
So like cleft lip, cleft palate, those were the examples,
For
right?
example, let's
Things like
say,
that.
yeah, something that doesn't affect, it's not going to affect the baby, okay? And on the other end of the spectrum are conditions where, no, the baby is so severely affected or you miss the time window that nothing that you do will change the prognosis. So those are excluded from treatment because they are beyond benefit. They are not going to benefit from the procedure. So the patients that we actually offer treatment for are the ones that fall in that middle window. The condition is going to progress. The baby will either die or the pregnancy will be lost or there will be organ damage. But you're still in time to change the course of things. You're not going to let the kidneys